After the introduction into clinical chemistry, we remain to the main questions that are asked in clinical chemistry, and the most important one is the use of clinical chemistry for the diagnosis. In other words, the question, is the outcome normal or abnormal? For this we have three options. To answer the question, we can use reference ranges, a consensus cutoff value for diagnosis that is based on risk or biochemical parameters, or a laboratory diagnosis of a particular disease, which is established using the Bayes theorem. We start with the establishment and use of reference ranges. For that we need to know what reference values of reference ranges are. For this we need to know the concept of health. It should be noted that reference values depend on method, which we will show, and there's many factors that influence reference values. All the knowledge on reference values will be applied in a case that is considered with fake complaints. A reference value or a reference interval or a reference range is a reference for values that are obtained by laboratory tests in patient samples, which can be blood, urine or other materials. A reference range is not a normal value, but usually it derives from a well-defined, apparently healthy group of subjects. The International Federation of Clinical Chemistry recommends to at least 120 subjects to be included in this. It should be noted that reference ranges do not reflect the actual range, but a 95% confidence interval. They are seldomly Gaussian distributed, and most times they are right skewed. This is because there's always subclinical pathology included. Reference ranges contain both inter-assay analytical variation and inter-individual biological variation. Please be aware that reference range values, or at least the selection of subjects for that, may contain inclusion or exclusion criteria, and this is done to limit avoidable sources of intra- and inter-individual variation. Those criteria can be, for example, fasting, gender, age group, or risks. It is important to remember that a medical diagnosis depends on more factors than the mere comparison of test results with a reference value. It should be noted that one deals with chances, not with exact established facts. But what is health? The World Health Organization states that health is a state of complete physical, mental and social well-being, and not merely the absence of disease or infirmity. In more recent years, this statement has been modified to include the ability to lead a socially and economically productive life. A more practical definition for the medical profession is: health is the functional and/or metabolic efficiency of an organism at any moment in time at both the cellular and global level. In any organism, health is the ability to efficiently and effectively respond to challenges, for example stressors, and effectively restore and sustain a state of balance, and this is known as homeostasis. So, health is not merely the absence of sickness. All organisms, from the simplest to the most complex, reside on a spectrum between 100% health and 0% health. There are many other health concepts. For example, Bircher stated that a dynamic state of well-being characterized by a physical and mental potential which satisfies the demands of life, commensurate with age, culture and personal responsibility. And for example, the Australian Aboriginal people say health doesn't mean just the physical well-being of the individual, but refers to the social, emotional, spiritual and cultural well-being of the whole community. This is a whole life view and includes a cyclical concept of life, death, life. What we consider determinants of health are genetics, lifestyle, the healthcare organization, but also public health. As stated before, for reference values establishment, exclusion criteria can be applied. These are, for example, diseases, because then a subject is not apparently healthy, but also risk factors. For example, obesity, hypertension, risk from occupation or environment, this means pollution or toxicity, and genetically determined risks, for example, a family history of disease. It may also include the intake of pharmacological active agents such as drugs, oral contraceptives, drug abuse, alcohol and tobacco. Sometimes specific physiological states are excluded, and these include pregnancy, stress or excessive exercise, because they all affect the outcomes of clinical chemical tests. The IFCC reference values contain at least 40, but preferable 120 samples from apparently healthy individuals. It is stated that when using 120 or more reference values, the confidence intervals for the fractals are reasonably narrow, and it is safe to consider a measurement above the upper limit of the confidence interval for the 0.975 fractal as an unusually high value. Reference values are a 95% confidence interval, and they are not a range. You can see this in this figure, in which we see the frequency distribution of triglycerides in serum. What we see on the left-hand panel is just What we see on the left panel is the distribution of the triglyceride levels, and on the right panel we see the 95% confidence interval depicted. It is very clear that 2.5% of subjects that are apparently healthy have values below the under limit. It is clear that 2.5% of the subjects have triglyceride levels below the lower level of the confidence interval, and also 2.5% of them have a level above the upper limit of the confidence interval. Reference intervals are mostly used, and for example, this is our latest reference value chart that is applied in the UMCG. Reference values depend on methods. For example, alkaline phosphatase. This is an enzyme that is used for bone health and other purposes. We see several methods that use several substrates and several temperatures, and we see that the use of the method, substrate and temperature leads to different reference values. It is therefore recommended always to use the reference values of the institution that provides the laboratory results, and not to take them from literature. With the use of the proficiency testing results, I already pointed out that there is a huge variation between laboratories for 25-hydroxyvitamin D that is used as a vitamin D status parameter. So again, we see here that there's a huge variation between laboratory results that derive from different laboratories. Not only the method influences the results, but also many other factors are known to influence lab results and thereby reference values. Genetics factors have influence on many outcomes, and also the same holds true for age. For example, alkaline phosphatase is dependent on age, but that depends actually on the growth of the subjects. During periods of huge growth, there is a huge increase of alkaline phosphatase. Socioeconomic status has an effect on nutritional but also on other environmental factors. The metabolic state, which means fasting or postprandial, influences glucose, free fatty acids and triglycerides. Posture influences blood pressure, and this is caused by an increase in noradrenaline when you are standing instead of lying down. Puberty influences sex hormones, and the same holds true for the menstruation cycle and menopause, but also pregnancy. Not only hormones are influenced by those factors, but also lipids, for example cholesterol, and in pregnancy we find a difference in hemoglobin. Hygiene and also public health influences the levels of immunoglobulins. Circadian rhythms influence notably cortisol and melatonin, which will be shown in a graph later on. Activity gives a small damage of muscles, and therefore creatine kinase, notably the muscle-derived one, is increased after extreme activity. But it also influences urinary calcium, nitrogen and phosphate. As the sun is shining abundantly during summer, it can be concluded that vitamin D increases in summer and is low during winter times. And this also holds true for latitude. Subjects among the equator have high vitamin D levels, whereas subjects in the northern Europe have lower vitamin D levels and status. It is well known that the height above sea level influences and increases hemoglobin levels. It's very obvious that nutrition influences the status of vitamins, but also a high-fat diet is known to increase cholesterol. Fish intake, for example, increases the status of the omega-3 fatty acids. So nutrition and nutrition intake increases and changes many factors. Also the use of recreational drugs increase carbon monoxide, but also alcohol increases, for example, gamma-GT. This slide shows the changes of noradrenaline or norepinephrine with posture. People who are lying down have low levels, and when you are upright it increases, and even more when there is a hand grip. The right panel shows the increase of triglycerides after a fatty meal, which was taken at breakfast, T is 0 hours. Applying the upper limit of the reference values of 2.0, one can see that some subjects have levels after the meal that are increased as compared to the upper level of the reference value. So this shows that it's very important to be fasting for an exact measure of triglycerides. We also see that there's quite some variation in the levels after the same meal, and also the time in which the maximum of the triglycerides in plasma is reached. This slide shows the plasma testosterone in males across the life cycle. It's high during fetal life, low at birth. It has a peak in neonatal life. It is very low in early life between 1 and 10 years old, and increases during puberty to reach a stable value in adulthood and decrease at old age. This slide shows the well-known differences in estrogens and progesterone but also the LH and FSH in the menstrual cycle, and the right panel shows differences in prolactin during lactation. Hormones in pregnancy change with a rapid increase of HCG during early pregnancy, which is followed by pregnane and estradiol in later pregnancy, and also many other factors are influenced by pregnancy, which is shown in this slide. Please note in the right panel that triglycerides go up during pregnancy and should not be used as a kind of measure of risk for cardiovascular disease. It is very well known and very functional that triglycerides are increased during pregnancy. Circadian rhythm influences cortisol with high levels during the day and low levels at night, and it also increases melatonin after dark. The left panel shows cortisol, the right panel shows melatonin. You can see that after the start of the dark period, melatonin increases rapidly and decreases after about 10 hours. As stated, physical activity influences, for example, calcium in urine, but also nitrogen and phosphate. And this is shown in dit gaat niet goed. Even stoppen. Urinary calcium, nitrogen and phosphate are dependent on physical activity, and during immobilization, calcium levels in urine increase hugely. We already discussed the seasonal changes in 25-hydroxyvitamin D as a parameter of vitamin D status. It is well known that vitamin D is synthesized in the skin upon exposure to sunlight. And for that we see higher levels of 25-hydroxyvitamin D during summer and low and very low levels during winter time. This is shown in both the left and the right panel. We also see that skin color is very important, with black women having lower levels also during the same period compared to white women. It should also be noted that reference values, for example in this example for homocysteine, are dependent sometimes on nutritional status. Homocysteine is a risk factor for cardiovascular disease, but the metabolism of homocysteine depends on folate and vitamin B12, but also vitamin B6. This slide shows that the vitamin B12 and folic acid supplementation change the reference range from higher to lower levels, and we concluded that maybe after supplementation the optimal levels were reached in the subjects that were supplemented, and they may reflect a more optimal metabolic procedure, which is reflected by the homocysteine. It should therefore be noted that reference ranges can be influenced by nutritional status. In this slide we see many factors that were discussed in the few minutes that were before. For example, we see a tumor factor that has different references for postmenopausal women as compared to premenopausal women. We also see gender in the transaminases. We also see pregnancy as a confounder. We see circadian rhythm in cortisol with a high level in the morning, low levels at night, and in between at the end of the afternoon. We see differences between males and females for a creatine kinase, which is a measure of muscle activity. We also see glucose that should be measured in the fasting state. We see that exercise influences growth hormone, but also gender. And so there are many factors that should be considered interpreting reference values. The use of reference values is explained in the case fake complaints. Imagine Mr. Peterson. He comes to your office, you are the GP, and he has a multitude of fake complaints. You hardly believe that these complaints point at some somatic disorder. He's a young subject, so the risk of disease is very small, but just to satisfy Mr. Peterson, you decide to order some clinical chemical tests, because you may never know, while it also buys you some time to wait and see. So you request the 20 most popular tests. The results show that plasma transaminase and triglycerides are above the upper limit of their respective reference changes. But what is the change that all tests are within the reference range? Because the reference range is a 95% confidence interval, and this means that the change of a value which is not within the reference value is 5% per test. Here we see the outcomes with a slightly elevated ALAT and elevated triglycerides. But for the triglycerides, we may ask the question, was the subject fasting? The transaminase, the liver enzyme, has a considerable biological variation. So is this a real change? But again, back to the reference values. They are not the actual range, and they are a 95% confidence interval. When you order 20 independent tests for healthy subjects, in order the pre-test probability equals to about 0, the chance of finding results of all of them within the reference range equals only 36%. This means that profiling or just ordering 20 tests is not a good idea. It costs a lot of money, but next to that, it brings you to the wrong conclusion. This graph shows the relationship between the number of tests and the probability of false abnormal tests. And it shows that the chance of a false abnormal test increases within the increasing number of tests. Why should there be profiled, or why should tests combined in test panels? Well, sometimes a combination of non-specific tests, but all with abnormal values, increase the probability of a disease. For example, we use bilirubin, the transaminase, both ASAT and ALAT, to detect liver disease. If they are all increased, liver disease is more probable than when only one of them is increased. The combination of tests, so the use of test panels, may also indicate the site of dysfunction. For example, we use bilirubin for liver disease, but we also measure conjugated and non-conjugated bilirubin. When there is a high level of non-conjugated bilirubin, this indicates that the cause of the high bilirubin is pre-hepatic. In other words, there's a high level of hemolysis that causes high bilirubin, and the bilirubin has not been conjugated in the liver, and therefore the cause is pre-hepatic. On the other hand, when there is high level of conjugated bilirubin, there is most likely gallbladder obstruction, because the bilirubin was elevated because of but it was conjugated. Thus this means that the liver is functioning normally, but there's obstruction in the bile duct, increasing the bilirubin in plasma. In the first part we discussed the use of test panels for example, preoperative screening. Since the outcomes may influence the outcome of the surgery, it is important to screen for diabetes, hypothyroidism, anemia and clotting diseases. We also know that some laboratories have problem-oriented lab forms. For example, there's first a screening for anemia, and when anemia is found, based on also the size of the erythrocytes, further tests are performed. Small size erythrocytes means that iron deficiency is likely, but also thalassemia or sickle cell disease. So the underlying cause can be found using those kinds of forms. Also for cardiovascular disease, more panels are used. Not only the use of both cholesterol, triglycerides, HDL cholesterol and LDL cholesterol, but also tests to find the underlying disease, since cardiovascular disease risk factors are treated lifetime. For example, high cholesterol can be caused by hypothyroidism. If you then treat the patient with high cholesterol with a statin, you do the wrong thing. The patient should be treated with thyroid hormones. The second way to determine whether an outcome is normal or abnormal is the use of a consensus cutoff value for diagnosis. In this lecture, we discussed two of them. We discussed vitamin D status, the 25-hydroxyvitamin D cutoff value that is based on biochemical relationships, but we also discussed the cutoff value for diabetes, for the diagnosis of diabetes, and for that we discussed the consequences of such a consensus diagnosis, and also the chance that an outcome deviates from the consensus cutoff value. In line with that, we discussed the number of tests that are required for a reliable estimate of the homeostatic set point. We go back to Christine Fransen. Christine has CF, and vitamin D absorption is low in CF patients. In this figure, we see the vitamin D2 level after supplementation, and we see that in CF patients there is impaired absorption of vitamin D, reflected in a lower vitamin D2 level, but also the 25-hydroxyvitamin D. The recommendation for vitamin D status in CF is set at the range of 75 to 150 nanomoles per liter. However, levels up to 250 nanomoles are probably still safe. These targets are based on the data outside of CF that demonstrated that PTH levels, which is a sensitive marker of serum ionized calcium levels, start to rise at low 25-hydroxyvitamin D levels, and those levels are below 75 nanomoles per liter. This graph shows the relationship between 25-hydroxyvitamin D and PTH. The parathyroid hormone is a sensitive marker of low vitamin D status. This biochemical relationship shows that the lowest PTH level is reached at 75 nanomoles per liter of 25-hydroxyvitamin D, and this is a very well used cutoff value for an optimal vitamin D status. Also, the relationship between risk factor HIP and non-vertebral fracture risk as a function of vitamin D status can be used to establish the optimal vitamin D status. This graph, deriving from supplementation studies, shows that at vitamin D supplementation, increasing the 25-hydroxyvitamin D level, there is lower risk of hip fractures, but also non-vertebral fractures at higher vitamin D. And it seems that up to 100 nanomole per liter, for which about 800 units of vitamin D is needed in those patients, that there is a decline of the risk of fractures. Also, there's a relationship between the plasma glucose in non-diabetics after oral glucose tolerance test, and it seems that the lowest glucoses are reached at a 25-hydroxyvitamin D level above 100 nanomoles per liter. As you can see, there's huge variation in plasma glucose, so this is not a real strong way to determine a cutoff value. The most convincing figure was the one that showed the relationship between PTH and vitamin D, and this is translated to our cutoff values that are used in the UMCG, in which we state that subjects with 25-hydroxyvitamin D levels above 80 nanomoles per liter have a sufficient vitamin D status. We consider a level between 50 and 80 nanomoles per liter as hypovitaminosis D, or in other words suboptimal, and levels below 50 but above 25 are considered insufficient. The whole world agrees that a subject with a level of below 25 nanomoles per liter has a deficient state of vitamin D. This shows that cutoff values can be achieved using the relationship between a parameter and another biochemical parameter. Another way to determine cutoff values is to calculate the risk of disease or a complication in line with, for example, plasma glucose or plasma glycosylated hemoglobin. And this is performed to establish the cutoff value for diabetes. Diabetes is a highly prevalent disease or condition. In the Netherlands we have about 800,000 patients with diabetes. 90% of them have type 2 diabetes. The prevalence is about 5%. Each year, the newly diagnosed subjects with type 1 and type 2 diabetes is about 4.5 per 1,000 subjects a year. It should be noted that there are many subjects with non-diagnosed type 2 diabetes. In the Netherlands, the percentage is currently unknown. However, in the UK, it was about 25% of the diabetes patients that was not diagnosed. Diabetes prevalence increases with age, and the increase starts to rise quickly from about 40 years of age. Diabetes mellitus is a lab diagnosis. In other words, the diagnosis is based on laboratory measures. There are three criteria for the diagnosis of diabetes. The first is a glycosylated hemoglobin above 6.5. The second one is a fasting plasma glucose above 7 millimoles per liter. And fasting is defined as no caloric intake for at least 8 hours. When a glucose tolerance test is used, which means the ingestion of 75 grams glucose at measurements 2 hours after the ingestion of glucose. When we then find a plasma glucose above 11.1 millimole per liter, then the diagnosis of diabetes can be set. If any subject with or without classic symptoms of hyperglycemia presents with a random plasma glucose above 11.1 millimoles per liter, then the diagnosis of diabetes is set. It should be noted that diabetes is associated with many risks, many complications. It's both macrovascular and microvascular. The macrovascular changes are already present at the stage before the diagnosis of diabetes is set.